chairperson, organizing team, distinguished guests, and participants here on site and linking in from around the world. I say a lovely good day to you from myself, Dr. Sonny Isemede, and from the team Patient Safety Africa that I here represent. I am a consultant, anesthetist, specialist advisor to the Care Quality Commission England, and director of Patient Safety Africa. It is a huge pleasure to be here to give this reflection on opportunities and quick wins for patient safety in Africa today. This reflection is based on the work not just of myself or a few people, but hard work of the entire Patient Safety Africa team, who I here acknowledge. To help us unpack this reflection in the next 26 minutes, we have a short intro, which will link on to a quick look at two models, one for patient safety investigation and another one for patient safety research. These are the models that informed us and supported us in the development of our patient safety and care quality improvement survey that we did in the run-up to the last World Patient Safety Day celebration. Following this, we will discuss the findings from our studies and identify areas of opportunities and quick wins. We'll round up with managing implementation and sustainability of change. So what is patient safety? We have had excellent definitions of patient safety in the last few years. We know that patient safety is not denial of harm. It is, in fact, the best risk management. It's not denial of risk or denial of harm, but best risk management. Patient safety is the structures and systems that we put in place to reduce the probability of adverse events occurring to patients in the process of healthcare. These have been very good definitions we've had. And I'm pleased to inform you all today that year 2021, we have a more comprehensive definition. That patient safety is a framework of organized activities that creates cultures, processes, procedures, behaviors, technologies, and environments in healthcare that consistently and sustainably lower risk, reduce the occurrence of avoidable harm, make errors less likely, and reduce their impact when they occur. But essentially, our focus is how to look at behaviors. What sort of behavioral modifications can we bring about to improve patient safety? What sort of technologies can we adapt or introduce? What are the positive cultures that promote patient safety? How can we improve processes? And to help us look at these, we use two models. One that looks, this is typical root cause analysis, looking at, situations when an event has already occurred. And, most of the time, what we find communication failure. But in addition to this, we also find that memory failures, attention failures are as a result of overwork. So when you have doctors and nurses working continuously for 48 hours, there are lapses and there are sleeps. If we put this in and begin to insist on, resilience rotas in Africa, where we have shortage of manpower and where we know many people, the few people available are overstretched, we got to make sure that we realize the problems that can occur. And so rather than waiting for the problems to occur, let us be proactive in making sure that we learn from this. We took another model. This is a proactive one. This is the Systems Engineering Initiative for Patient Safety, SIPS, that was developed by Pascal Carrier and our team at Madison in 2006. And what it tells us is that errors in healthcare are not usually associated with solitary, one single element or one single individual. It's usually a system approach. And a whole lot is involved in actually trying to improve patient safety. So you have a process, you have a structure, a process, and an outcome. Within the work stream, you have persons interacting. So it could be a patient coming into a healthcare system. You have a nurse or a midwife or a doctor meeting with that patient. There's a task, a healthcare task for that patient. Is this staff adequately trained? Does this staff have the right tools and technology? Is this staff supported? Does he have enough water in that health facility? Does this staff have sanitizers? Are there PPEs for this staff to keep the staff safe so that the staff can keep the patient safe? What is the organizational culture like? What is leadership? What is support for staff like? All these are intricately linked to the outcome that you get. And these outcomes, we hope they are desirable, but sometimes they are undesirable. What's important is that are they fed back to the patient and to the healthcare worker? Is this feedback there that helps people to learn? Because you need to learn from events. So looking at these two models, we're able to focus on work systems, the processes, and the outcomes to develop the SMART indices. These SMART indices are specific, measurable, achievable, relevant, and time-bound indices of healthcare quality. At time zero being 17th of September 2021, which was the World Patient Safety Day. So So we had, the focus was on team approach to care, on communication, on protocol development, on protocol use, leadership, data management, and learning from events. So we had 10 domains with a maximum score of 100. And so we had survey questions on that persons looking at the use of staff ID and patient ID. We had task questions relating to tasks that have to do with the use of care bundles, data management. There were questions relating to tools and technology, talking about medical devices, whether there are logs for every medical device and their functionality, in other words, the service histories. How are these organizations using information and communication technologies? There were a lot of questions about organizational culture. We looked at infection prevention and control, the availability of water, of sanitizers, of PPEs, and leadership for infection prevention and control. We looked at transfusion history, transfusion safety, medicine safety, surgical safety, and the things here were, incident reporting, especially, drug error reporting, incident reporting and incident management, feedback loop. And this, we looked at clinical governance, which is leadership, communication, and learning. So from all these, the 10 domains, maximum score of 100, we had several hospitals in over 12 countries across Africa, respondents from over 12 countries we had results. And here are some of the results. So for infection prevention and control, these are the results. I'm just going to breeze through them for time. You will have these slides. You have blood transfusion safety. These are some of the results. So we looked at training, we looked at leadership. Again, availability of wristband. I'll come to this later. medicine safety, look at insulin pens, we look at incident reporting system for medicine safety. Surgical safety, we looked at the World Health Organization surgical checklist. Bit disappointed was 65.71, but it's a starting point. Surgical incident reporting was 58. But this is not the most important thing. It is not the number. It is more than number. It's very easy to rush to publication of these figures here, that the use of basic wristband for patient identification in the hospitals of respondents in this survey is less than 25%. And these hospitals where there's blood transfusion going on, where there's surgery going on, some of these hospitals where there are COVID patients who might be in and out of coma. So how do you actually identify them? Yes, you can make a publication out of this, but that's not the most important thing. You got to realize that these are people who are coming with generosity of spirit. They are enthusiastic to start a continuous quality improvement journey. They have come in with candor. And what they're wanting from us, what they want is for us to meet them at their point of need. What they want us to add value to them and to support them in their journey from where they are right now to where they are going. So publication of their, present state is not the priority. What we found more important than these figures was the message, the free text. This became more powerful as far as we're concerned. So we saw here a call for standardized training. And then there's a second comment talking about a common language emerging. We're very pleased with this. And this is why many people are calling our study quality care index. I don't want to see it as percentage or as a league table, but it's really there. If you're starting at 30 out of 100, the plan is for that hospital to look at what is possible in the next 3 months, and then we work with them. It's not about comparing this hospital as having 30 with the one having 70. And there was another comment. How do we make quality care training count towards staff promotion? How do we make this training relevant? There are many staff in Africa who have needs in their professional development. Can we plug this training into it? Like we have a number of registered nurses in Africa who want to progress onto the BSc nursing program. Why don't we have a system whereby we can put patient safety training onto that so that they have patient safety training, they come out from the other side with a BSc, they get a raise, they get a better status. I think that would be more attractive. And then there was this question about fear of punishment. This is talking about persistence of the blame culture in the Africa health environment. So what do we do with this? Like I said, our focus is not on the figures they brought, but we want to support this group. We want to support this team. And this is what we're doing, telling them we're with you all the way. We're going to work on this together. We understand you. We believe you. And because we've established that relationship, we're able to begin to deploy these basic tools. So patient ID and allergy coding is now being deployed in a number of the hospitals, and we're developing systems to make that process easier and better. So this will help with blood transfusion, with surgical safety and medicine safety. Again, with pulse oximeter use is becoming fairly standard in Africa. What we're trying to do here is support hospitals